Good afternoon, everyone, and welcome to Transfusionist Talks, Transfusion Made Bloody Easy. My name is Donna Berta, and I'll be talking with you this afternoon. My coworker Sheena is in the background, keeping all the technology things running smoothly. Our topic for today is C1 esterase inhibitors and immune serum globulin, or IMIG. As we begin, I would like to start with a land acknowledgement. So as we gather, we begin by acknowledging that this virtual event is hosted from the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish One Spoon Wampum Agreement. Please take a moment and acknowledge and reflect on the land where you are joining. As you've noted, this is being recorded, and the recording may be used for educational purposes. By participating, you are giving your implied consent. I don't have any conflicts of interest to declare. The information in any of the patient cases is completely fictitious, fabricated for this learning. The presentation, the recording, it will be posted on the OrbCon Transfusion Ontario website if you go to this link, and then if you go to resources, then click on presentation library, and then you have to scroll down and you can find all of the current and previously recorded events there. During the presentation, if you think of any questions, you can just type them into the chat and we'll have time to talk about them at the end. So feel free to do that. I am going to be asking you some questions throughout, and just to make sure everyone is familiar and okay with the technology, the polling technology, we'll just launch this question just as a test run. So we're just asking about your current role, and here you can just select one choice. Okay, that's great. I think everyone's got that down pat, so that's good. Thank you. My mouse does not want to cooperate. Before we get too much into things, I just want to make quite clear that C1 esterase inhibitors and immune serum globulin, or IMIG, they are very distinct separate blood products. They're not interchangeable in terms of their indications or uses or anything like that. So we will talk about them separately as we go through. I will begin by asking you a question, and this question we'll ask it now, and then we'll ask it again at the end of the presentation and see if you have any other thoughts as we've hopefully got some learning going on. So Frida is a young adult. She has episodes about twice a month of painful facial swelling, her eyes and her lips. It takes about 3 to 5 days for this to go away, but it does cause her to miss time from work. She doesn't have any kind of rash or itching or trouble breathing when this happens, and she's largely ignored these episodes, thinking it was just must be something she ate. Her family, though, is quite concerned and want her to seek medical attention. Frida should seek medical attention because, and here in this question, you can select all that are applicable. So she might have a serious anaphylactic reaction. She might be a candidate for long-term disability. She should be tested for hereditary angioedema, or a medication or other blood products such as Berinert might help relieve some of her symptoms. And I'll give you a moment there to see what you think. And again, you can select more than one. Okay, we'll stop there, and we will come back to this question at the end. I have another question for you. And this time it's about a 5-month-old infant. Pebbles was at her babysitter's yesterday for the Monday for the full day. They had a visitor, the babysitter's sibling, and that person has now been diagnosed with measles. This person was not vaccinated for measles as a child. So Pebbles, who weighs 7 kilos, should receive measles post-exposure prophylaxis, and you can select again all that are applicable from the choices there. So she should she receive the vaccine as soon as possible within 6 days of her exposure? Should she receive the vaccine but can be for up to 6 weeks? Should she receive Gamistan IMIG within 6 days of exposure, or is it okay for her to receive that Gamistan within 6 weeks of the exposure? And again, you can pick all that are applicable there. Okay, we'll stop there, and then we'll move on to the presentation. And we're going to start out with talking about C1 esterase inhibitors. I want to answer the questions that people submitted when they registered. Some people submitted some questions. Hopefully you'll be able to recognize and understand the clinical indications for this blood product and how to give it to a patient safely. I do have a bit of an outline, and we'll follow along with that as we proceed. So C1 esterase inhibitors, they're lyophilized, so they're a powder, a concentrated powder of human C1 esterase inhibitor protein. Has to be reconstituted. They give you a diluent sterile water to do that, and it's done with the mixed to vial transfer device, the same device that you would use to reconstitute Octaplex or Baraplex PCCs. Why does someone need C1 esterase inhibitors? They're indicated specifically for the treatment of hereditary angioedema. And we'll talk a bit more about what that is. The products that we have available in Canada right now are Berinert and Haegarda. They come in 2 different strengths, and we will talk more about that as we go along. C1 esterase inhibitors have been used for some time. Berinert came along in 2010. Haegarda was more recent in 2021. They have been used in Europe for many years. The strength, again, is in international units. They are a blood product. They're made from plasma, pools of plasma, sort of similar to IVIG. So informed consent, lot number traceability, all of those things are very important for these blood products. The manufacturing process I've listed on the screen there because these steps do increase the safety of these products by reducing the viral risks. So what is hereditary angioedema? It's attacks of painful swelling. There's not any itching. The swelling can be in an asymmetrical distribution, so it could be just one side of someone's lip, something like that. They are very random, these episodes, and often unpredictable. It can vary over the patient's lifetime in terms of how often they have the attacks and how severe they are. The duration is somewhere around 3 to 5 days if they're not treated, and they usually would start in adolescence or early adulthood. They typically can affect the arms and legs, the bowel mucosa, the genitals, facial, and also can be life-threatening, affecting the airway. And I'll just click on this link here to show you from the Canadian network website some of the pictures of what this swelling can actually look like. So you can see that these are all facial pictures that these patients have submitted, but it's pretty significant, and the airway limitations, and this is a child. So it is a very significant disorder. In terms of the abdominal swelling, they don't show any pictures of the abdominal swelling, but I have seen some, and certainly it looks like the person is 9 months pregnant, ready to deliver at any moment. It can be that significant. So this disease does cause functional impairment to patients, and if it involves the airway, if there isn't treatment given, the mortality is about 30%. So it certainly is a very serious condition. We do know that there are some triggers, physical trauma, such as during a medical procedure or dental procedures affecting close to the airway, that can trigger an attack, but it's very inconsistent. Even minor procedures might trigger an episode of angioedema. Emotional stress can be a factor, and some patients have identified other factors that they know of that are specific to them. The prevalence of this disorder is about 1 in 50,000. So how do these C1 esterase inhibitors work? Well, it is hereditary. It's an autosomal dominant inheritance. So that means that if one parent has the gene defect, then 50% of the children could potentially have it. C1 esterase inhibitors, they're produced in the liver, and their actions, the things they do, they inhibit complement, they inhibit the clotting cascade, fibrinolytic activity, and most importantly, for the pathogenesis of hereditary angioedema, they affect the kallikrein systems. And the kallikrein systems are ultimately responsible for the production of bradykinin, and bradykinin has many functions. The ones most important here that we're concerned about is the ability to increase capillary permeability. So fluid can leak from the capillaries to the tissues, causing this edema. They also constrict smooth muscles and stimulate pain receptors, so that gives the pain with the attacks as well. And so if you don't have enough C1 esterase inhibitor, or if it isn't functioning properly, then the kallikrein systems are going to be in overdrive and a lot of bradykinin is going to be produced. Hereditary angioedema has been categorized, and there's H into 3 levels. There's HAE1, which means the person has a deficient level, so they don't have very much C1 esterase inhibitor, and that's about 85% of the people with this disorder. In HAE type 2, their C1 esterase inhibitor is normal, but the level is normal, but it just doesn't function right, and that's about 15% of the patients. And then there's an additional category formerly called HAE type 3, and now it's called HAE normal C1 esterase inhibitor because their levels are normal. And we don't know how often this happens, primarily because we don't have good assays or genetic testing to make this diagnosis. An international consensus conference has recently defined some criteria to make the diagnosis based on symptomatology and response to various treatments, but more work is certainly needing to be done there. The treatment options that we have in Canada, as you can see from this list, there are several. Before we talk more about that, I just want to point out that there is treatments for acute attacks. So when somebody is having an acute episode, and they're called sort of on-demand treatments, we want to treat early and appropriately to decrease the severity and the length of the attack. And then there are also prophylactic or preventative treatments, which are regularly scheduled. So they, again, would reduce the frequency of attacks and the severity and hopefully make it so that people are not having to take as much time off work and things like that because it's under better control. In terms of the products listed here and treatment decision-making and pharmaceutical treatments, they are beyond the scope of this presentation. So I'm going to talk specifically to the blood products that are used. And so for acute attacks, we can see there's Berinert, and for prophylaxis, there's Haegarda. And you can see as well that these products, even the medications, are given via different routes. So it can be a little bit confusing. I will also point out that plasma can be given to treat an acute attack. It's not the first line of treatment, but if you had a serious acute attack that was affecting the airway and you didn't have Berinert or Firazyr available to give to the patient, then plasma would be a reasonable option according to the Canadian guidelines. I will also point out that Cinryze is approved. It is a blood product and it is approved for prophylactic treatment, but it currently is not on the Canadian Blood Services formulary, so it's not available as an option in Canada at this point in time. I'm going to stop now and ask you a question. So you're a nurse working in IMIG in a small town. It's Saturday at 2 in the morning, and Betty comes in with severe eye swelling and lip swelling. She doesn't have any shortness of breath. Her vitals are within normal limits. There's family with her because she's from out of town. She's visiting. She has been diagnosed with Alzheimer's disease, so she's not a very good historian. The family do know that Betty's had this kind of swelling problem off and on for some time. She doesn't have any allergies, but they really don't have any other information. So the emerge physician, what are they likely to do? And I'll give you a moment to look. And again, you can select multiple answers here if you feel there might be multiple things to do. So will they order epinephrine? Will they start an IV? Will they call the allergist on call at a nearby hospital? Will they order some Berinert? I'll give you a moment to look at that. Okay, it looks like people have voted and interesting responses. I'll stop that poll and then we'll just talk about things. So epinephrine, if somebody presented like this, they may well give epinephrine. Is it likely going to help if this really is hereditary angioedema? No. Epinephrine, that's for an allergic response where histamine is causing the problem, and in hereditary angioedema, it's bradykinin that's causing the problem. So it's not likely to help if that's what this is, but we don't know and we don't have a lot of history, so that does seem like a reasonable thing to do. Starting an IV, again, that's probably a reasonable thing to do with a patient presenting in this kind of way. Calling an allergist on call, that might be a good thing to do if you don't know a lot about hereditary angioedema. Usually these patients are followed or treated by allergists or immunologists. And ordering some Berinert, if the physician is comfortable and they have it on hand, also seems like a reasonable thing to do in this scenario. This, again, and part of our problem in this scenario is we don't have a lot of history. This is an example wallet card that can be printed from the Canadian Network website, and it does give you the information that you would need in terms of what the recommended treatment would be for this patient if they're having an acute attack. It gives you their physician who to contact, gives you some guidance about what to do. And there is a place here to add some other information as well. The guidelines are pretty specific. They do say that patients should have ready access for a treatment for an acute attack, either at their home that they would give themselves or at their nearby hospital. Prophylactic treatment can be given as well, but it doesn't eliminate the possibility of having acute attacks. So all patients who have HAE need to have an acute attack plan. Short-term prophylaxis can be considered prior to procedures. Again, you would want to evaluate the degree of physical trauma involved. So Berinert, we'll talk about Berinert specifically. So the indication for Berinert is acute laryngeal, or abdominal hereditary angioedema attacks. It has been approved for pediatrics age 5 to 16 and adults. The dose is 20,000 international units per kilo. It does have a half-life of about 90 hours approximately. The two vial sizes are a little bit interesting to have to work with because the 500 international unit size it's reconstituted with 10 mils of sterile water that comes in the kit or the package. The 1500 international unit strength, it is reconstituted with 3 mils of sterile water. So the concentration in each of the vials is very different in terms of volume, but you do have the international units. Berinert should only be given IV. Patients do learn to give them this to themselves at their home. Again, it's a bit of a challenge because they are starting an IV, they are giving themselves an IV medication. So to maintain competency and skill there for an on-demand treatment can be challenging. And patients also need to be very good about keeping documentation records of what's going on with them with this disorder. The manufacturers and the society, the Canadian HAE network, do have some apps that patients can use, so it can be make it a bit easier to document as well. So Berinert does have to be reconstituted. So again, follow aseptic technique. It's a single-use vial. That mixed to vial transfer set that's provided, you need to use a new one for each vial of Berinert that you're reconstituting and only use the diluent that's provided. There are some resources for the steps to reconstitute. If that's something that you want to look at, it's there. The other thing, once you have reconstituted, again, with the two different strengths, there is a bit of a difference there. So the 500 international unit one is colorless and clear. The 1500 international unit one can be slightly opalescent. So there is a difference there just when you're looking at it. And you would, of course, as you're reconstituting, label the Berinert per your hospital policy. So traceability is very important and a topic that's very near and dear to my heart because we want to make sure that we track all of these blood products should there ever be any specific concerns or recall with them. So we have to make sure that the lot number is documented on the patient's health record. So just like checking any other blood products, you're going to again check the surname, first name, unique identifying number on the armband, the transfusion order, the transfusion label, and the chart health record. And you also want to confirm the lot number on the manufacturer's label, on the chart label, and the health record label so that everything is very clear. The transfusion medicine standards also require that the identity of the person who did the reconstitution, who prepared the product, is documented and the date and time of preparation. So your hospital, if they're stocking these products, will have specific policies on how that's done in your hospital setting. So I'm going to ask you another question now about Betty. Her physician, the physician looking after her, does decide to order the Berinert 1500 international units, and that would seem like an appropriate dose because she's about 75 kilos and 20 international units per kilo. That's a good dose for Betty to be given IV slowly, not greater than 4 mils per minute. So the blood bank sends you 3 packages or 3 kits of Berinert 500. You reconstitute it, so you have 3 syringes with 500 international units or 10 mils to be given. So true or incorrect, you should administer the Berinert each 500 international unit or 10 mil syringe over 2.5 minutes. And I'll give you some time to look at that as well. Okay, and most people said this was true. That is how fast that you can give it, and that is correct. It's to be given not greater than 4 mils per minute. So if you're giving 10 mils, that would be over 2.5 minutes. Once you've reconstituted Berinert, it should be used immediately. It should not be put in the refrigerator. The rate per the monograph is slow IV injection. So again, that maximum of 4 mils per minute. So a 500 international unit dose you could give over 2.5 minutes. The 1500 international unit dose could be given over 1 minute because it's a smaller volume. To give someone like Betty a treatment, uh, it would take you about 7.5 minutes at least of pushing that medication IV direct very slowly. So if the patient isn't in dire straits, you could put that into a mini bag and put it on a pump and let it go in over 10 minutes. That would be a fine thing to do as well. That would be appropriate. The kit does that the blood bank sends you. It does have a butterfly needle and there's tubing in it because again, patients do this at home. So it's all provided there. So you have both options. The mixed to vial set, of course, includes a filter so you don't have to worry about filtering. Like other blood products, don't dilute it, don't mix it with any other medications. You need a dedicated IV site, flush the tubing with the Berinert before you start, and it is compatible with saline, so you could flush it afterwards as well to make sure she got the full dose. In the monograph, they do provide some information about how long it's going to take before you can expect to see this helping your patient. And so if it's a laryngeal attack that they're having, where they're having airway swelling problems and stridor, it should help within about 15 minutes. For an abdominal attack, it may take a bit longer, 30 minutes. So just some guidance there in terms of what to expect. Patient monitoring, as if it, again, if it's given in the hospital, if patient's giving it to themselves at home, they're not going to be doing this. But in a hospital, we want to take some baseline vitals and a full set of vitals with all 5 parameters being assessed so that if there is a reaction, we have a baseline. Patients who we're giving Berinert to in a hospital, they should be monitored for the onset of symptom relief and for any potential side effects. And we'll talk about what the side effects that you would be watching for are. If you do see any kind of a side effect or adverse reaction, it would be the usual blood transfusion steps where you would stop the transfusion, keep the IV going, check vitals, verify patient ID, talk to the prescriber, whatever the prescriber orders, and of course, reporting the reaction to the blood bank is a very important step as well. So what kind of reactions do we see with Berinert? The most serious reaction that we see with any frequency at all is an increase in the severity of the pain. Unfortunately for the patient, that can be seen. There are other more common things such as headache, affecting your sense of taste. It can cause some abdominal symptoms as well, muscle spasms, peripheral edema, upper respiratory infections. Very rarely with Berinert has allergic or anaphylactic reactions been reported, but if so, again, you would want to contact the provider immediately. Patients with thrombotic event risk factors should be closely monitored because they have been reported, thrombotic events have been reported at the recommended dose at higher than label doses and with off-label use. So it is something to be aware of as well. Angiotensin converting enzyme inhibitors, ACE inhibitors that are used to treat blood pressure, they should be avoided in patients with hereditary angioedema because they decrease the degradation or the breakdown of bradykinin. So they're going to contribute to the amount of bradykinin that's available as well. So you want to avoid those in this patient population. It is contraindicated if there's any kind of a hypersensitivity or previous reaction. In terms of pregnancy, there's limited information, but from retrospective case reports, there have been no reports of any complications or harmful effects on neonates in a pregnancy situation. Again, breastfeeding has not been studied, but you have to weigh off the benefits against the risks and make some decisions there. So we're going to move on now to another question for you. And this time, June is Betty's youngest child, and she has been diagnosed with hereditary angioedema type 1. So she has a decreased level of C1 esterase inhibitor. She's been diagnosed by an immunologist, And she has eye swelling attacks that happen 3 or 4 times a week, and she's not able to go to work on those occasions. So it's really impacting her life. She has become proficient in administering the Berinert for acute attacks, IV, but she's still having attacks. So she's gone on to, with her physician, decide to try the long-term prophylaxis treatment. So her physician orders Haegarda, 4,000 international units, IV slowly twice per week. So this treatment should decrease the severity and frequency of her attacks, and I'll let you vote there for true or false. I'll give you a moment. Okay, and so most people said true, and it does look true. I have to confess that this was a little bit of a trick. Haegarda, the long-term prophylaxis one, if we just go back and look at that chart, if I can go back there. Haegarda is the long-term prophylaxis one. It is not given IV, it is given subcutaneously. So that's the problem with this order that we have here. So this is the wrong route. And I've seen that happen many times. It gets very confusing in terms of which product and which med is given and by which route. And so you do have to be very careful and check something like the monograph or a chart like that or something to make sure you've got the right stuff when you're giving this. But it is very confusing, and physicians find it that way too and will order the wrong thing. So Haegarda is indicated for the prevention of attacks in pediatric and adult patients. It should not be used to treat an acute attack. The dose is 60 international units per kilo twice a week, so every 3 or 4 days it's given. It is slowly absorbed, takes about 60 hours to get to a peak concentration. It as well comes in 2 vial sizes, but they are more consistent in terms of the concentration. It's 500 units per ml. So the 2,000 international units is diluted with 4 mils that comes in the package. The 3,000 is with 5.6 mils. So that is more consistent, not creating such a problem there. Again, it's usually, it's only given subcutaneously. Usually it would be given in the abdomen, can also be given in the upper arm or the thigh or buttocks, and patients will learn to self-administer this. There is a patient education support program. Again, documentation records that the patient has to keep are very important. It does have to be reconstituted, so patients would have to learn that as well. Again, it's a single-use vial. It's with that mixed 2 vial transfer device. You always want to use a new one for each vial. Only use the diluent that's provided because it's the right amount for the concentration. There are resources to review the reconstitution steps if you like. One of the things to be aware of with reconstituting Haegarda is that it does say specifically in the reconstitution steps that you need to be sure to swirl it until it's fully dissolved. It can take, it's usually within 5 minutes, but it could take as long as 10 minutes to dissolve it. If there is any particulates in the Haegarda, you don't want to use it, but both strengths should be colorless and clear. And again, it would be labeled according to your hospital policy if you were giving it in the hospital. Traceability is the same for Berinert. We've gone over this. There's nothing different there, but it is a very important thing to make sure that the lot numbers are tracked should there be any recalls or any series of adverse events, etc. So Haegarda, the monograph, does give us some more guidance. It should be used immediately, but it can be at room temperature once it's reconstituted. It can be stored for up to 8 hours. The only caveat there is that the storage has to be in the vial, so it can't be drawn up in the syringe and kept. It has to be stored in the vial if it's going to be. It doesn't specify a specific rate to give it. It just says slow subcutaneous injection as tolerated by the patient. The package that you get with the kit does contain a sub-Q infusion set, so a needle, a butterfly, and a syringe. And it is recommended that you inject it into a single site at each administration, and then you rotate the sites for the next dose. Again, not to be diluted or mixed with any other medications, flushing the tubing, of course, beforehand. And with the Haegarda, there is information in the monograph that the sub-Q dosing twice weekly, the number of attacks and the number of times that the patient would need to use acute attack treatment is decreased with this treatment. The numbers that they put in the monograph are a bit confusing to understand because they also talk about how long the patient's been on it when they were making these calculations. So it's not the most straightforward, but it does show that that Haegarda is effective. Okay, we're going to go back and talk about June, another question about June a little bit more. So June's been on her long-term prophylaxis for about 8 months. She's been doing well on it. She's only having 1 attack a month now compared to her previous 3 or 4 a week. So doing very, very well. She administers her Haegarda on Mondays and Thursdays in the evening. She's been really busy lately, and today she suddenly realized that she forgot to give the Haegarda on Monday. So she's going to give Monday's dose tonight, and then she's going to go back to her regular Thursday evening routine tomorrow. Is that the best thing for June to be doing? And I'll give you a moment to answer there. Okay, and as most of you have indicated, no, this is not really a good thing to do. The monograph specifically tells us that the patient shouldn't be doubling up on their doses. So, June could give herself her dose tonight because it's been a while since she's had one. She doesn't want to get into trouble with more attacks happening. But then she needs to not give it tomorrow and needs to space it out again and get back on track if Mondays and Thursdays really work the best for her. So you would not just give that extra dose right now. So some other things about Haegarda, patient monitoring. It is usually a self-administration at home that a patient's doing, so there's not any specific monitoring, but the patients do need to do a lot of work. And again, that app is available if they want to use it because they need to document the date and times of their treatment and any side effects. They need to document when they have attacks. They need to document if they need to give themselves acute attack treatment, just so that they can be prepared and assess how they're responding to the treatment. If they have any side effects, they should be notifying their prescriber, and they should also be reporting them to the blood bank where they're picking up the Haegarda, even if those side effects are minor, that should be reported. So what are the side effects that might happen? There can be some subcutaneous injection site reactions like pain, redness, swelling. That's not uncommon. Other reactions are dizziness, hypersensitivity with itching and a rash, or nasopharyngitis can happen as well. Allergic reactions have been reported. So again, if a patient had that kind of a reaction, they would need to contact their healthcare provider right away. The product monograph, in terms of talking about thrombotic event risk factors, is a little bit vaguer in terms of saying that they haven't seen a causal relationship when Haegarda has been used as it was intended, so at the appropriate dose and the appropriate indication. So that's what their recommendation is. Nonetheless, it is something to be aware of. Again, we don't want to give the ACE inhibitors in these patients. If they've had a reaction, then we would not want to give it either. In terms of pregnancy and long-term prophylaxis, the Canadian guidelines do specify that even though the data is not of high quality, when long-term prophylaxis is required in pregnancy, Haegarda, the plasma-derived C1 esterase inhibitor, would be what would be recommended for these patients. And again, you're weighing benefits against risks in making that decision. Okay, so we finished talking about the C1 esterase inhibitors. We're going to go on to talk about immune serum globulin, IMIG, or the brand that we have available is called Gamastan. So it's a sterile solution of human immune globulin. It is a 15 to 18% antibody concentration, as opposed to IVIG, which is standardly, most preparations are a 10% solution. So it is a bit more concentrated. It is made specifically for IM injections, and the peak levels happen about 2 days after the IM injection. It is made from plasma, so again, informed consent, lot number, traceability are important. The manufacturing processes to increase the safety of this product are listed on the screen as well. So how does it work? What does it do? It provides passive immunization if a specific vaccine was not available for active immunization, or in cases where the vaccine wasn't given prior to the exposure, or if the vaccine is contraindicated in a particular patient. And there's 4 different infective agents that we're looking at with giving Gamastan. And so the first one is hepatitis A. So if someone has been exposed, there is a prophylactic dose that can be given, but it should be given within 2 weeks of the exposure. If someone's going to be traveling to a place where hepatitis A is quite common, then there are some dosages that can be given depending on the length of stay that the person has planned. For measles, which is very much in the media at this point in time, Gamastan can be given to will prevent or modify measles in patients who have been exposed. So that means they've not been vaccinated or they've not had the measles previously. And this is particularly important for kids under 1 year of age, because that's where the risk of complications is highest. So the dose is 0.25 mils per kilo, and you would need to give it within 6 days of the exposure. Gamastan and the measles vaccine, the MMR vaccine, should not be given at the same time. So these babies would get it later on. With measles, if children are in an immunocompromised state, or if there's other severely immunocompromised patients, if they've had contacts, then they can as well be given Gamastan, and that would be regardless of their immunization status. Again, to be given within 6 days of exposure. In terms of rubella, Gamastan can be given specifically to during the first trimester of pregnancy in someone who would not consider a therapeutic abortion and they've been exposed to rubella. For varicella, it can also be given if the specific varicella zoster immunoglobulin is not available, if VZIG is not available, and you would need to give this promptly. There is not a role for Gamastan in hepatitis B prophylaxis. There is, again, a specific product, hepatitis B immunoglobulin, that is often given in combination with hepatitis B vaccine that would be preferential. So it's those 4 conditions where Gamastan or IMIG would be used. Again, traceability is very important. We've talked about that already, so I won't go over that again, but very important and applicable to the Gamastan. How it comes, Gamastan, it comes as a liquid. in a 2 ml single-use glass vial. It's stored refrigerated, so you would want to bring it to room temperature, hold it in your hand for a bit before you are going to give an injection of it. Again, it's IM injection only. Uh, and it's very specific in the monograph that they want you to be sure that it's not going into a blood vessel. So draw back on the plunger to be sure. And again, that's because the risk of an anaphylactic reaction is higher if this was given IV because it's a more concentrated immune globulin. So it's very important that it is given only IM. If there are doses over 10 mils, then it should be divided and put into several different sites. Again, not to dilute it, mix it with other medications. The color of this product can be a little bit variable. It could be clear, it could be a bit opalescent, it could have no color, it could be pale yellow or light brown. So there's a range there. Again, Gamistan can interfere with the response to live viral vaccines, so these kinds of vaccines should be delayed for 5 to 6 months post Gamistan. Before we talk further, I just want to point out that there has been, with the recent measles outbreak, there has been some controversy and discussion, and new information was put out by the National Advisory on Immunization Committee in terms of giving this stuff, because it's typically been said that if the patient weighs more than 30 kilos, we shouldn't be giving the IM version, the patient should get IVIG. And just because of discomfort and the volume that you'd need to give. And that's probably a factor, but in remote areas, it's not a hard and fast rule, I guess, is what they're saying in the NACI document, because giving IVIG also carries some extra work as well and risk in terms of infection control practices to bring someone in and give them IVIG. So it's not a hard and fast rule in terms of that 30 kilos, depending on the specific circumstances. But IVIG is an option for those patients as well. Okay, so when you're giving Gamistan, again, baseline vitals, always important, always something that we should be doing. If a patient is receiving this in an outpatient environment, then it is ideal, like for other vaccines, like when you get a COVID vaccine or a flu shot, that you stick around for a little while afterwards in case there's any side effects or reactions. If there is a reaction, again, we need to notify the prescriber and report it to the blood bank, even if it is minor. So what kind of reactions can you get? Again, injection site reactions are not uncommon. Other things like fatigue, fever, headache, nausea can happen. Allergic anaphylactic reactions have been reported with this stuff. And if there are symptoms, then you again want to contact a healthcare provider immediately. And as I mentioned before, it's more likely if it is inadvertently given IV, so be very careful to give it only IM. There has been an association determined between any immunoglobulin and the incidence of thromboembolic events. So, and these thromboembolic events with immune globulins can occur in the absence of risk factors. So you do want to exercise caution and monitor patients appropriately. Again, contraindications, if there's been a reaction previously to this, if someone has an IgA deficiency, then we would not want to give it because we wouldn't want them to develop an IgA antibody. And if someone has a condition where IM injections would be contraindicated, then again, we would not want to give this. There is no specific recommendations on pregnancy or lactation. Again, if it was given, should be given to a pregnant woman only if clearly indicated. Okay, and so we've gone through the information. We'll go back now to the questions that I asked you in the beginning. So the first question was about Frida, who's a young adult who's had these episodes of painful facial swelling with her eyes and lips. And now we're looking at, should she be seeking medical attention, and why would that be? And you can go through, again, this is you can select all that are applicable, so you can select more than one answer. And I'll give you a moment to go through there. Okay, I think everyone who wanted to vote has. So we'll just go through here which answers we might think were appropriate. So Frida might develop a serious anaphylactic reaction. Certainly that's possible. And so that would be a reason, because you don't know for sure that this is hereditary angioedema until she's had the testing. So it would be good for her to seek medical advice. In terms of being a candidate for long-term disability, that's probably something that would not likely be thought of until way down the road if, she was in such a situation where she couldn't work at all. So that's not top of mind. She should be tested for hereditary angioedema. Yeah, I think with the symptoms that she's reporting, that would certainly be something that should be undertaken. And a medication or a blood product like Berinert might relieve these acute episodes. And indeed, if she is diagnosed with hereditary angioedema, that would be something to consider. So basically, we're looking here at A, C, and D. Okay, and now we'll move on to our other question. So this is about the little 5-month-old infant who was exposed to measles. And now in terms of measles post-exposure prophylaxis, again, you can pick more than one answer. And so the options are MMR, within 6 days of exposure, MMR within 6 weeks of exposure, Gamastan within 6 days of exposure, Gamastan within 6 weeks of exposure. I'll give you a moment to consider that. Okay, and here there is only one correct answer, and that would be C, the Gamastan to be given within 6 days of exposure. In terms of giving MMR now or within 6 weeks, nope, it's kind of like the exposure has already happened, so it's too late for that. So that's not something that we're going to do right now. And the Gamastan, it does need to be given within 6 days, so that's the appropriate answer there, answer C. I'm just going to flip back for a moment to our previous question here. When we're talking about Berinert and patients coming to emerge, if somebody with hereditary angioedema has that wallet card, they're showing up in emerge, they've probably tried to do what they can do at home, so they're probably in a bit of a bad way if they're actually coming into emerge, because these patients are often very good at looking after themselves. A question that was put in the registration questions was, should a nurse give the patient's medication that they're bringing in with them? And the answer to that is it really would depend on your hospital policy and what your hospital allows you to do. But certainly, if a patient came in and they were were not doing well, and they brought the medication with them and they had some kind of documentation to say they had hereditary angioedema, I certainly think it's reasonable to administer the medication that they brought. Now, if you have it in your blood bank and your blood bank can get it down there, that's probably a better route to go. But if you don't have any Berinert or Firazyr and they show up with Berinert or Firazyr, and they've got documentation, then I think it would not be good not to give it. So, with that, I do have some references here to refer to. Uh, I do want to acknowledge the Ministry of Health because they provide ORBCON with our funding, and I do want to thank my ORBCON and transfusion medicine family for their mentorship and support. Specifically, Sheena, Laura, and Allison, my colleagues, help to make these presentations possible. I want to thank you. Your participation is appreciated. I hope you have found this helpful, and I thank you for your attention. Some updates, just to let you know, the Transfusion Medicine Bootcamp for Nurses is coming up on November 26th. If you go to that presentation library on the website, you can access the recordings of the past events of that as well. Next Transfusionist Talks, September 24th and then March 26th. If you have any topics or cases that you want to hear about, or want to have discussed, certainly send me an email. I will, if there's any questions that you've put in the chat or you want to enter any further questions in the chat, please go ahead and do that now, and we have a few minutes to go over those. And finally, here is the QR code for the evaluation survey so that you can get your certificate of attendance. Again, thank you for your attention. And Sheena, do we have any questions?
There are no questions currently in the chat.
Okay. We'll give you a couple of moments if you think of any.
The link will come out in an email actually after we're finished here, so probably tomorrow. Someone asked if we could put the link to the survey in the chat. I don't have it readily available, so I apologize for that.
Yes, we will send it out tomorrow. Okay. If we don't have any questions, then I guess I'm giving you back a couple minutes to your day. I thank you for your attention. I hope you found this helpful. If you think of any other questions that you want to ask, certainly you can always email me. Okay, hope you have a great rest of the day.